So welcome everyone. I'm Marianne Levitsky with Workplace Health Without Borders. And I want to welcome everyone here today. It is so exciting to have such an international audience. And we have invited people to say hello and put their name and where they are in the chat. So please do so. It's lovely to see where everybody is from. You may have noticed I have my Zoom background today is a sunflower field. Sunflowers are the Ukrainian national flower, and with the blue sky, they form the Ukrainian colors. And I think all of us have Ukraine on our mind now, as we do everyone who's living in a war zone and under conflict. So I'm sure they're all in our thoughts with hopes for peace throughout the world. Also, this week is the second anniversary of the declaration of the pandemic. So we are not only thinking of people who are suffering from war, but from all the people who have suffered from the pandemic, and those we have lost are people that we think about, especially this week. And I'm going to turn it over to Audrey Cunningham, our moderator. Thanks, Audrey.
Hi, everyone. Yeah, glad to see you all. So I want to introduce our first speaker, Chris Keane, President-elect of the British Occupational Hygiene Society. And a little bit more about Chris. Technical lead for occupational hygiene at HSE's Science and Research Center in Buxton, leading role in the Breathe Freely Champions program, which aims to equip other BOH members with materials and skills to speak at public events on behalf of our society. If you want to, Chris is going to talk about assessing ventilation and managing COVID airborne transmission risks. So Chris, if you want to start, that would be awesome.
Thank you very much, Audrey. Thank you very much, Marianne, and thank you for getting the slides up. Thank you to everyone for attending this afternoon. It's a real honour to be invited to present something to Workplace Health Without Borders. It's obviously a fantastic organisation that does great work around the world, and I'm really pleased to have been given the opportunity to speak for you. So I'm Chris Keane. I'm the President-elect of the British Occupational Hygiene Society. I'm going to talk for 15 minutes or so on assessing ventilation and managing airborne COVID transmission risk. Next slide, please, Marianne. Just a quick thanks before I start. A lot of the knowledge that I've obtained over the last 2 years has been obtained through working on the UK government's Protect research programme. So this has been a large research programme. It's involved researchers from numerous organisations across the country looking at various aspects of the pandemic. So much of what I've learned around ventilation for COVID has come through my work on the Protect programme, and I'm grateful for the opportunity to have worked on that study. Next slide, please. So just to be clear here what we're talking about, I'm talking about managing airborne transmission risk, okay? I'm not talking about surfaces, I'm not talking about fomite transmission. I think it's safe to say that most COVID infections have occurred as a result of airborne transmission in one form or another, okay? And that is via what we break into two main transmission routes. So you've got the direct droplet transmission, the near field transmission. This is transmission which will happen within 1 to 2 meters. This is a result of droplets being emitted from an infected individual and flying straight through the air and landing, you know, in the breathing zone of a receptor, of a host. Short range direct droplet transmission. These are fairly large droplets and they don't remain airborne for very long at all. They fall to the floor very quickly, and certainly beyond a couple of meters, you are not at risk from of infection via the droplet route. And then we have aerosol transmission, which is going to be where I'm going to focus my talk for the next 15 minutes or so. So this can happen in the far field, much further than 2 meters. When we breathe out, or when we emit droplets as we breathe and speak, you've got a various size range of droplets coming out, and even the large droplets evaporate very quickly. They become lighter. The lighter they become, the longer they will remain airborne, the further they can travel through the air. So when we're talking about aerosol transmission, we're talking about far field transmission, and you're not necessarily safe even if you're beyond 2 meter distance from an infected individual. Next slide, please. So just coming back to the direct droplet transmission, just to reiterate what I said on the last slide, this is near field, less than a couple of meters, generally within a meter. Quite straightforward to control this transmission. It's not always easy to implement these controls in the real world, but in theory, if we could all remain more than 2 meters away from everyone else, if we can erect things like physical screens or barriers, which will take out these droplets because they fly in a straight line, they don't follow the air currents, these are large droplets, and face coverings, both on the infected individual and on potential receptors, will all reduce transmission risk via the droplet route. Next slide, please. When it comes to the aerosol route, it's a little bit more complicated. As I've said, these are smaller particles. They will remain airborne for much longer. They will travel greater distances than 2 meters. There are a number of risk factors for aerosol transmission. Clearly, it's almost exclusively it will happen indoors. It's very unlikely that aerosol transmission will go on in an outdoor environment because of the ventilation rates outdoors. So obviously the principal risk factor is the likelihood of actually having infectious individuals within the indoor space in the first place. The duration of any interactions is important. Aerosol transmission is most likely not going to happen in a single instant. So the longer that individuals mix together in a single space, the higher the risk of aerosol transmission becomes. The activity within the space is a factor. If people are sat at rest, just breathing normally, they will emit far less droplets than if they're stood up, if they're shouting, if they're conducting hard physical activity, singing, or worst of all, if they're coughing and sneezing. The amount of aerosol that's emitted from these events is much, much higher. And ventilation, the more poorly ventilated the space is, then the higher the risk becomes. So clearly ventilation is a very significant risk control for this transmission route. Next slide, please. So just a few basics around ventilation. First of all, air movement in indoor spaces can be very, very complex. Air doesn't always do what we expect it to do. Anyone that's familiar with CFD modeling, or anyone that's ever seen air movement visualized in a room, will realize you get all sorts of eddy currents whirling around, you get air flowing back on itself, you get dead spaces in the corners of the room. So air movement can be quite a complex thing. There's no doubt that ventilation can be a really effective control to reduce transmission risk, good ventilation. And what we've found, certainly on the Protect research that we've done in the UK, when we've been into outbreak situations in a workplace environment, that the people that are actually managing these spaces, that are actually managing these buildings, their knowledge of ventilation is really rather very limited. Beyond controlling the temperature in the space, they don't really understand ventilation very much at all. Next slide, please. So mechanical ventilation I'll touch on first. So just to be clear here, we're talking about supplying clean outdoor air into an indoor space. We're not talking about recirculating air conditioning systems. They will not reduce the transmission risk in anything like the same way as supplying clean air. They can be effective if they've got decent filters in them, but you're much better off supplying clean outdoor air into a space using a mechanical ventilation system. Within the UK, I guess in other jurisdictions, other parts of the world, you have your own building regulations. We have building regs in the UK. They specify minimum air supply rates into various different indoor spaces, okay? What we've found when we've assessed ventilation in outbreak settings is that there's quite a high proportion of buildings in the UK don't actually achieve the rates that are specified in the building regs. So it's not good enough to assume that if you've got a mechanical ventilation system, it will be turning over the amount of air that's specified in the building regs. Certainly in the UK, a lot of buildings aren't achieving these air supply rates. And I'll touch on this bit later on, but mechanical ventilation, if you don't have a mechanical ventilation system in your building, you're going to find it very, very expensive to retrofit one. Next slide, please. How much clean air do we need to control the aerosol transmission risk? Well, within the UK again, and I say your own national regulations will be different. We talk about 10 litres per second per person of clean air being fed into a space. That won't remove the aerosol transmission risk, but we would deem that that would give you adequate control. It would bring the risk down to an acceptable level. If you have a mechanical ventilation system in your space, it's highly likely before the pandemic that it was recirculating a proportion of the air to save on energy bills, to stop throwing, warm air out of the window in the winter time. A lot of mechanical ventilation systems would have been set to be recirculating a proportion of the air. So it could well be that systems have had to be reconfigured to actually achieve this 10 litres per second per person. prior to the pandemic, other than sort of specialised healthcare settings, which I'm not discussing here, I'm talking about general workplaces here. Most people don't think about health risk management. When they thought about their general ventilation systems, they were there to control the temperature, they were there to control the humidity, to control the comfort levels in that environment. They weren't there to protect against the transmission of an airborne virus. So people, even people that did understand their ventilation systems to an extent, didn't understand them from the perspective of controlling airborne transmission risk. Next slide, please. I'll move across to natural ventilation now. We're all familiar with the concept of natural ventilation. We all, I guess, at some point in our homes will open the window if it gets too warm, if it's too stuffy, if we're cooking, things like that, to remove smells. You can provide natural ventilation in an indoor space via a variety of means, as you can see up on the slide there. It can be, next slide please. It can be really, really simple to implement a natural ventilation solution. In some spaces, it can be as straightforward as opening windows, okay? And we found that the simple act of opening windows, certainly in some small, poorly ventilated indoor spaces, just opening the windows can increase the ventilation rates by an order of magnitude. And that can be all you need to do if that's possible. Next slide, please. If you've got a much more complex space, a much bigger space, and I don't expect you to be able to take in the detail on this slide, but this is I think it's a 6-story university building. So you've got, you know, hundreds, thousands of students using this building. It's got a natural ventilation system in there, but there's much more going on in there than just opening a few windows. You've got wall louvers, you've got roof vents that open and close depending on the temperature. So natural ventilation can be quite a complicated thing. Next slide, please. But it is often the most practicable option. As I said before, if you don't have a mechanical ventilation system already installed in your building, it's going to be a big job and an expensive job to install one. So you're left then relying on improving your natural ventilation to adequately control the aerosol transmission risk, okay? And I've said that open windows, open doors can provide adequate ventilation, but that's going to need some kind of management and supervision if it's going to work properly. Certainly in the UK, and I guess in other parts of the Northern Hemisphere, it's quite cold outdoors in the winter, and people don't always want the windows wide open. So you're going to need some management and supervision if you're relying on open windows to control the transmission risk. The good news is that the ventilation rate is dependent on the temperature gradient and the air movement. So the greater the difference between indoor and outdoor temperature, the less wide you'll have to open the windows to achieve adequate ventilation. So you don't necessarily have to have the windows wide open in the middle of winter time to achieve adequate ventilation via natural means. Next slide, please. I'll just say a quick word about sort of standalone air cleaners, air filtration systems. They're not really a substitute for ventilation. They can offer a solution if you can't achieve adequate ventilation by other means. You need to think very carefully about where they're situated, about sizing the filtration unit for the size of the space and the number of people in the space. So as I say, not as effective as ventilation, but they can offer some sort of solution if ventilation by other means is not possible. Next slide, please. Excuse me, just let me take a drink. So I'm going to move very quickly onto assessing ventilation. So under the Protect study, my team went out into a number of workplace environments that were actually experiencing a COVID outbreak amongst their workforce. One of the things that we had to do was to assess the ventilation in those environments, and we thought about doing this in various different ways. We settled quite early on using carbon dioxide measurement to assess ventilation, and I think most of the rest of the world have gone the same route. It's a fairly practical, accessible option. You don't need a lot of expensive kit. You don't need sort of sulfur hexafluoride tracer gas and things. It's relatively straightforward to do, but you do still need a level of expertise to apply it properly and to interpret the results. It's not enough to just buy a carbon dioxide meter and walk around taking spot readings. You need to understand what you're doing. But it is a very, very useful tool to prioritize risk and to provide assurance to the users of indoor spaces. Next slide, please. I'm not going to go into all the detail on this slide. There's tons on there. I've put it up for reference. If people want to look at the presentation afterwards, This is from one of our sort of scientific advisory committees to the government in the UK that discusses when it is and isn't suitable to use carbon dioxide measurement to assess ventilation. So as I say, if you're really interested, go back into the slides and have a look. There's too much information on that slide for me to go through. Next slide, please. When is carbon dioxide measurement not suitable to assess a space? Okay, if you've got other carbon dioxide sources present in the space, combustion being the obvious one, then clearly using carbon dioxide measurement to assess ventilation is a non-starter. We're relying here on the only source of CO2 in the space being human respiration. So if there are other CO2 sources present, either from combustion or often in food factories and some in other industrial processes, they'll use CO2 as a process gas, then you're not going to be able to use this method to assess ventilation. And if you're using filtration or sterilisation to clean the air, as I put up with the standalone unit a few slides ago, then clearly they will take out airborne particulate or they will kill airborne virus if you're using sterilisation. They will not remove CO2 from the air. So again, you're going to get false readings if you're using CO2 to assess ventilation in that kind of situation. Next slide, please. So just a few simple facts around this. I guess a lot of you will know this. I'm just sort of reiterating this. Obviously, to assess the ventilation using carbon dioxide measurement, you must do this while the space is occupied at normal, typical levels. You cannot go around a building that's empty at the weekend and use CO2 measurement to assess ventilation. You have to have the space occupied at typical occupancy levels. It's much better to measure over a period of time, to leave an instrument in place logging for a period of days or even weeks, than wander around taking a few spot measurements. You'll get much richer data from measuring in that way. And you need to understand the occupancy data at different times of day. So if you leave an instrument logging in a space, you need to understand how many people are coming into that space, how long they're staying for, what time they're coming in, what time they're leaving, to allow you to interpret the results. There'll be different guidance around the world in different countries, I guess, but certainly in the UK, we've settled on these numbers. If you're getting less than around 800 parts per million carbon dioxide in the space, we would say that indicates adequate ventilation. And if you're getting above 1500 ppm, we would say that indicates a pretty urgent need to improve the ventilation in that space. Obviously, there's a fairly wide band between 800 and 1500. The closer to the top end of that band you get, then the more likely you need to be doing something to improve your ventilation in that space. Next slide, please. This is just one example of a trace. This is from an office where there had been a COVID outbreak. So we went in, we set up a carbon dioxide monitoring program in this office space. You can clearly see the periods of when the office is not occupied at the weekend, you're down at 400 ppm, which is background level in the general atmosphere. You can see 4 or 5 spikes in the week. You can even see that it was Easter one week, so people didn't work the Monday. So you can see a long weekend at the beginning. You can see 4 spikes that week. You can see 5 spikes the next week. So you can clearly see the occupied periods. You can clearly see that you're getting CO2 levels above 1500 ppm in this office environment, indicative of a need to improve the ventilation. Next slide, please. So just to summarize, ventilation is often the weakest link in workplace COVID controls. People understand social distancing. They understand the need to keep a distance from one another. They understand the need for good hand hygiene, for good surface hygiene, surface cleaning. It's ventilation where people often fall down because, as I say, air is invisible, we can't see it. And it's often the thing that certainly in workplace outbreaks, often the thing that's gone wrong, okay? As I've showed you, just opening the windows can provide significant, adequate ventilation to mitigate the risk. So solutions can be achieved without significant capital investment in some situations, okay? And if you can't improve the ventilation any further than you already have done, then the next logical step is to start reducing occupancy levels or occupancy time. All of these will bring down the risk. Next slide, please. As I've already said, reliance on open windows and doors requires management and supervision. If you open windows and it's cold outside in the winter time, certainly in the UK, people are going to close them again. There needs to be some sort of program in place to ensure that those windows remain open. And it's not always going to be that straightforward. If you've got a complex environment, you've got restrictions as to what you can do with your ventilation for various reasons, then you may well need a specialist solution. It could well be that you don't have the knowledge and expertise in-house to come to a suitable ventilation solution yourself. So you may have to bring in a specialist, okay? And it's important to remember that ventilation, no matter how good it is, will not mitigate against the close range direct droplet transmission, the stuff that occurs within 2 meters. Next slide, please. Just to finish, really, just to reiterate, I think we all understand this. There is no single control that's going to prevent COVID transmission in any space. You've got 3 main transmission routes. You've got the direct droplet, you've got the long range far field aerosol, you've got the surface and hand contamination. So you're going to need a suite of controls to control the risk adequately. We've tried to represent that here using the Swiss cheese model, which you're probably familiar with. Other people have used different models, but this is just to remind that there is no single solution. You cannot control the risk with one single control. Next slide, please. Just a very quick mention of our own ventilation tool. I know other speakers are going to speak about ventilation tools that they have developed. BOHS, we have developed one. It's available on our website. You can see the link on the slide there. It's very easy to use. It doesn't provide all the solutions for every single space, but it certainly sets people in the right direction when it comes to assessing their ventilation systems. Next slide, please. And I think I've almost finished. I've put some references up on this slide just for people who want to go in and have a look and gather some more information. I apologise that most of these are UK specific. This is the area that I'm most familiar with, so I've given you a lot of UK guidance. But at the bottom there is the ASHRAE ACGIH COVID white paper, which is an excellent reference document. And I'm sure there's plenty of other things on there as well. So forgive me if I've missed your particular guidance document off that slide. And I think, Marianne, that's me finished.
Chris, that was great. That was so interesting. And reiterate what Chris said. Go back and look at the presentation because there's a lot of really good information there.
Yeah.
Our next speaker, this is John Udick. And John's he's an occupational hygienist, occupational health clinics for Ontario workers, and he'll talk about a tool to assess ventilation. A little bit more about John. He worked with the Hamilton Clinic of Occupational Health Clinics for Ontario workers since 1989. He's been active following infectious disease exposure and prevention developments in healthcare and other settings since SARS-1, advising, and he's carried out site exposure investigations and conducted extensive surveys of healthcare workers. He's been a member of research teams investigating the conditions of infection transmission. And please go ahead, John. Thank you.
Thanks for joining today. I'm going to give you some ideas on how you can assess your ventilation in your workplace. But first, let's check in how we're doing. Worldwide, we're approaching 500 million people who have been infected. And there are over 6 million people now who have died because of COVID. In the United States alone, they are approaching 1 million deaths. And when you look at this stratification according to income, you can see that the high income countries are having the worst of it. Here is a comparison of the infections per day per million people in Denmark in orange and Canada in blue. You can see quite a difference in a higher rate of infections in Denmark. However, there's quite a difference in the testing strategies. If we look at the testing strategies, you can see here that Canada is only testing a fraction of the people that Denmark is testing. So if we look instead at deaths per day per million people, this evens out the comparison a bit. And you can see that for Canada and Denmark, we've had a similar death experience for the pandemic, except recently. Since Denmark opened and dropped all measures in the beginning of February, its death rate has risen to a quite high rate, whereas Canada's has lowered. And the reason they gave was they decided that their population is responsible enough that they can manage the pandemic at an individual level, not requiring state intervention. And this seems to be the latest trend, downloading responsibility for assessing risks and determining which precautions to take, leaving it all to the individual rather than directing it from a central decision authority. And this is a graphic that the Public Health Agency of Canada put out just before Christmas, telling people how they can assess their risks. So we put together this spreadsheet, which is available at this link, to help you evaluate the ventilation in your workplace. It says it's for classrooms, but it will also work on other smaller rooms and meeting room size rooms. Starting off, you describe the workplace, the type of ventilation, the size of the room, and the capacity. It also calculates whether the distancing is achievable. Next, you put in the room ventilation rate. Now this can be a little more difficult to get, and I'll describe a number of ways you can get at this number. So it's really the tough one to get. First of all, you can ask, but when you ask, are the people you're asking actually competent enough to answer? And do you trust them to be looking after your health? You can find out what the requirements are for your type of workspace. And there are standards, but sometimes these are difficult to find. You can also check if you or someone you trust has access to the ventilation drawings. You can get the numbers from there. You can also have a look inside the HVAC unit with somebody who knows what the parts are. It's a good way to learn about the system that's providing the air to your workplace. You can assume, if you don't have access or you don't have trust of the people who are giving you information, you can make some basic assumptions and compare them to what you're being told. And finally, you can actually measure it. You can get somebody competent to do it, hire a consultant, or you can actually learn how to do it yourself. So how much air is coming into your workplace? If you find someone who knows, people like a maintenance person, a caretaker, a person who comes in to look after the ventilation system, or a health and safety rep. And you might want to check to see if they just know the number off the top of their head, or they actually have some piece of paper or some documentation to back up what they say. And if not, who knows? One of the things you need to find out is how much of the air that's being circulated through your room is actually fresh air. What's the percentage of outdoor air or fresh air? And generally, again, the same kind of people might know, but there also might be documentation. As a rule of thumb, generally ventilation systems are designed to provide anywhere between 10 to 30% outdoor air, and the rest is recirculated air. You can check the ventilation drawings. Here's an example, and you can see within this room there are 3 vents, and each one provides a different amount of air, 210 CFM, 200 and 170 CFM, and they're coming through 10-inch by 4-inch grills that are in the wall. And when you add it all up together, this room is getting 580 CFM. Now you may also see something like this, which is a vent. One has 135 CFM, the other has 75 CFM, and they probably look something like this on the ceiling. And the lower number, the 8 with the 0 with the slash through it, means it's an 8-inch diameter. You can also check the manual for the heating, ventilation, air conditioning unit. And here you see a boiler plate, which gives you the model number, and you can go on the internet and look this one up. Also under the manufacturer, and you can find the service manual, and in the service manual you can figure out which system is your system, and you can find out how many CFM, in this case 3000 CFM. You can also assume, if you don't have any other information, generally HVAC systems that meet the ASHRAE standards provide 15 CFM of outdoor air per person, roughly. Also, there's another way of figuring it out. Generally, systems are designed to provide approximately 6 complete air turnovers per hour, and this includes both outdoor air and recirculated air put together. Another design rule of thumb is 1 CFM per square foot. So if you have a 300 square foot room, you can assume a total recirculated airflow of about 300 CFM. As mentioned before, most HVACs provide 10 to 30% outdoor air, so let's just assume 20% outdoor air. You can vary that if you think they're providing more. And between these assumptions, along with the room dimensions, you should be able to estimate the airflow through your room from the HVAC system. You can also have outside people come in and do a proper measurement of how much air is moving through each room, and this is called an air balancing report. And what this does is they go to each diffuser and measure how much air is going through it. So for instance, here are all the cubic feet per minute for each of the diffusers, and if office number 4 is our office, we know that we have 191 CFM of air, total air, recirculated plus outdoor air coming through the room. Here's another sample report, and here are some of the machines that are used to measure the airflow. And you can see here that the supply for this patient room is 97 CFM. However, the return together is about 153 CFM, and if you calculate it out, you can figure out how many air changes per hour, and that would be about 7.7 air changes per hour. You can also see that they checked which way the air was flowing with a smoke stick. This is a little stick that produces smoke, and you can, as you open the door, you can see whether the air is coming in or coming out. You can measure it yourself. This is a plastic garbage bag with a coat hanger put around it, and here you can see it's being put over a register in a home, and you can measure the time that it takes to fill up the bag, either with a stopwatch or with your cell phone. And from that, knowing the volume of the bag and the time it takes to fill it, you can figure out how many cubic feet per minute is coming through that register. Here's an example of me doing it. You place it over the diffuser and you time it from when it fills up. And it takes a bit of practice. You should do at least 3 measurements just to make sure they're within the ballpark of each other, about 10 to 15% of each other. And that's one way that you can measure the airflow in your room. You can also get an estimate of how much air is flowing through your room by measuring the carbon dioxide. It's a surrogate. We exhale carbon dioxide, the air comes in and dilutes it, and so you can figure out how much dilution is happening by measuring the CO2 concentration. You have to make sure your CO2 is reliable, your CO2 meter is reliable, and the way to check it is make sure that the outdoor air concentration is somewhere around 400 to 450 parts per million. The ASHRAE 62.1 2016 standard has an equation in it, and it uses occupancy and the percentage outdoor air, and you can correlate that with the peak concentration of carbon dioxide. Also, as we mentioned before, outdoor air intake rates are usually between 10 to 30%, so if you assume something like 20%, here we have an example where we have 2,700 parts per million of carbon dioxide in a room with 20 people and 30% outdoor air, and the equation will give you the result of 301 total CFM recirculated in outdoor air going through the room. And if 30% of that is outdoor air, then the amount of outdoor air per overall room would be 90 CFM, and if you divide 90 by the 20, you'll see we're much lower than the 15 CFM that's recommended by the standard. The Ministry of Labour in Ontario put together some guidelines years ago, and they recommended that if you have less than 600 parts per million of carbon dioxide, you're fine. If you're between 600 and 800 and you have complaints and you have other factors also involved, you might want to do something about it. If it's between 800 and 1,000 and complaints are more prevalent, and you should think about increasing the outdoor air. And at 1,000, you have insufficient outdoor air, and you should bring that up. Now the next section in the template, the calculator, has to do with filtering. And here you need to find out how good the filter is, and there are different ways of measuring it. MERV is the one that's used for HVAC systems, but here there's a kind of 4 different types and shows you the equivalent in other types of rating systems. In order to figure out what kind of filters you have, you can ask people, but you should also have a look. Go up when with a competent person, open up, shut off the machine and open it up and have a look at what it says. You can read it on the side of the filter usually, and they can look like many different things. Here are some different types of filters and various stages of cleanliness. The next stage in the spreadsheet is to look at portable air filters. And these are based on the Clean Air Delivery Rate numbers, or CADR numbers, and you can find these online or in the manual. You can also make your own. Here's a picture of a CBC news item where Jeffrey Siegel is describing how to put tape a filter to a box fan and use that instead of the more expensive units. And when he compared them to the others, the box fan with the MERV 11 filter was quite comparable to the more expensive portable filters. And here's a Corsi Rosenthal box, which is 4 or 5 of these filters built on. It becomes more efficient the more filters you have. And it's a way of cleaning the air much more efficiently and for a lot less the cost. Finally, we have any supplementary fans. If you have a fan just blowing things around inside, that's not necessarily advised because you might be blowing someone's emissions from one person to another. But if you're blowing it out a window, you can figure out how much air is leaving and how much would be coming in to replace it. So once you put this all into the spreadsheet, you have your final result and it's ready for posting on the door. So here we have our door. We post it so everyone can see when they enter the room what type of ventilation system is being provided in this room. Thank you very much.
All right, for next speakers, we have Molly Isbell and Brian Schmaler with Signature Science. Dr. Isbell is responsible for the operation of quality assurance and data scientists. And beginning in 2003, she's played a key leadership role in the development of QA programs and systems for statistical analysis support for field and lab testing. And Brian is Vice President of Marketing and Business Development at Signature Science. In this role, he's responsible for planning and execution of the company's business development funnel, from opportunity identification and capture strategy through to the contract award. He served as principal scientist and program manager, having led technical projects in the areas of measurement and signature intelligence. So go ahead. Whoever wants to start.
I'll go ahead and start. So we just wanted to say thank you for giving us the opportunity to present the COVID-19 exposure assessment tool, which we refer to as SEAT, to this group. So SEAT was really developed by Signature Science, primarily by Brian Schmoller, and he'll be giving a demo of the tool here at the, after I get done talking, he'll be giving a demo of the tool, but I also assisted with the development of this. as well as other collaborators and contributors that most of whom we connected with through the COVID-19 International Research Team. It's a consortium just in dealing with various science related topics related to the COVID pandemic. So if we go to the next slide, really what is SEAT? Brian, I think you're controlling this. There you go. All right, so SEAT is an interactive PDF tool. It's designed to be an easy to use tool for managers and event planners looking at group exposure associated with various group activities. So when people are coming together and there's a risk of exposure to COVID-19, how do we take into account the various considerations and factors that could be impacting the risk? And so we put together this PDF tool where users can enter information about the event and then come up with a relative risk estimate based on that. So the concept really behind SEAT really just grew out of internal work here at Signature Science as the pandemic was happening, and we were looking at, initially nobody was coming into the office, then people started to return to the office, both to the laboratories or for meetings and other activities. We were trying to look at how do we do that in the safest manner that we can. What are the different factors that would impact the risk associated with that? What are the different mitigation strategies that we can put into place? How does that really impact the risk? And we wanted to take a look at this in a really scientifically rigorous way, as well as we wanted to be able to quantitate the risk so that we could make really data-driven decisions as we were looking at one scenario versus another, and how do we combine the various mitigation strategies. And so initially it was really just an Excel tool that we were developing internally, but at the same time we were involved in other consortia and groups working on various aspects related to COVID-19. And we started talking to some of the folks from the Covert team about the ideas and what it was we were trying to do. And we started to bring in those areas of expertise. And we realized that if we could develop a tool like this would have broad applicability to others as well. So over time, we continued to refine the model and work on the model and come up with the algorithms. And we developed this interactive PDF that we have actually made publicly available. It's a beta version, but it is publicly available for other people to use. And just kind of thinking about the origins of why did we develop this to begin with, really our target was looking at group exposure based on gatherings that were happening. And the users really are people who are enrolled similar to what we were finding ourselves in at Signature Science. They're the organizational health and safety managers, potentially industrial hygienists, trying to piece together all the different factors that could be impacting risk and come up with an assessment. So there's a little graphic on this slide that shows the various factors that all play into risk, many of which were already talked about today in the previous presentations. But what the tool does is it allows a user to go in and sort of turn the knobs or turn the dials associated with these different factors and say, if I can change some of these characteristics of whatever the activity is, how does that impact the risk? So we take into account some stochastic factors as well as mechanistic factors, sort of the physics of what's happening in the room. But it's things like, what are the group specific characteristics? Is this a group that is highly compliant with the public health guidelines? Is it a group that we don't know if they're compliant or not compliant? Do we know anything about the vaccination rate? Is there any kind of testing strategy in place such that before you can enter or partake in the activity, you've been tested within 3 days? So kind of what all those factors are that might affect sort of that event and group specific likelihood of infection. The number of people that are going to be in the space and participating in the activity, as well as the activity level. And I think it was Chris Keane talked about, or one of the previous speakers talked about that activity level being really important because that affects both the exhalation rate of someone who might be infected unknowingly, as well as the inhalation rate of the other people who might be impacted in this group exposure situation. It takes into account whatever kind of masking and distancing requirements you're putting in place, the duration of the event, because that also does affect exposure. And then much of what's already been talked about today, both the venue size as well as these ventilation factors. So is it indoors versus outdoors? So it actually looks at risk both associated with indoor and outdoor activities. If it's indoors, how big is the room? What are what's the volume of the room? the air changes per hour to the extent that that's known. What do we know about the room filtration? And then also it also looks at what's going on in the local community. So what is the infection rate? What's the vaccination rate in the community in which this event is taking place? And then again, as the pandemic has continued to evolve and we've learned more and more, and we've had the different variants coming out, there's also a way to then to go into the tool and say, okay, you know, right now it's all Delta, or right now it's all Omicron, or what proportion of the infections seem to be one variant or another, and then how does that affect the transmissibility? So as we learn more and more about what's happening, that's also a factor that can be input into the tool to then understand how that is affecting the exposure. So those are the different factors that are taken into account. If we go into the next slide, Brian, there's a few features of the model that we wanted to talk about, and there's not time today to talk about all of the mathematics behind the model and explain the different kind of the algorithms and the way that's all taken into account. We have developed a draft manuscript that we are submitting for peer review and publication. That manuscript is available on bioRxiv, and we'd be happy to talk to any of you guys in a lot more detail probably after this meeting about some of the algorithms and the modeling approaches behind it. But for purposes of what we're wanting to show you today, there's some things about the tool that I think is important to understand. So, you know, we talked in the previous slide about the fact that a user can come in and turn different knobs associated with the event, kind of what the scenario is. The way we built the PDF tool, which you'll see in just a minute, the way we built the tool is you can actually enter information side by side associated with kind of with two different events side by side. So you can say, what if I change the number of people, or what if I change the duration of the event, or I change my masking strategy? So you can kind of turn the knobs differently for the two different events, and then sort of see side by side how is that impacting the risk. And we think that was sort of important as you're thinking about how to come up with different mitigation strategies and what those impacts might be. Another important thing to understand about the tool is what is it, how are we expressing the relative exposure risk? As we were doing this, we wanted to come up with a quantitative number, but we also understand that just a number is like, what does that mean? What does a number of 100 mean? What does a number of 10 mean? Is that low? Is that high? So we said, well, what really makes sense is let's benchmark this. Let's benchmark this as something that we can describe, so that when you look at that number, you've got a frame of reference. So we looked at the United States Occupational Safety and Health Administration. So the OSHA has a definition of a high-risk scenario, which is it's two individuals in a relatively small room, I think in terms of feet instead of meters. So kind of a 10 by 10 room with 9-foot ceilings. So, you know, with kind of standard ventilation. So it's two people sitting about 3 feet apart in this room for 15 minutes. One of whom is known to be infected, the other one is not infected. So what is the risk to that currently uninfected person in that scenario? So that is defined as a high risk scenario by OSHA. And that is our baseline scenario. So whenever we're calculating the risk of exposure, it's all what's the risk of exposure, kind of the group-wide exposure for this event relative to this baseline event. So if there's a value of 1, it's saying it's the same risk as this baseline event that we're talking about. If it's a value of 100, we're saying the group-wide exposure risk is 100 times greater than in this baseline scenario. If it's 0.1, we're saying it's much lower than in this baseline scenario. So that just gave us a way to put some definition to what's a sort of a high risk, which is a value of 1, a very high risk, and then medium and lower risk. So again, that's just an important thing to understand about the tool. And I said I'm not going to spend too much time, and I'm not going to spend too much time talking about the mathematics and the models and the algorithms that are behind this. But one thing that is important to understand, because it's a novel feature of the model that we've developed, and that is it does rely on first principle methods, so kind of the physics and the engineering to estimate the concentration and dispersion, and it's combined with probabilistic methods based on infection rates. But when we're looking at the concentration of virus that might be in the room and the dispersion and sort of what someone might be exposed to, One of the things that's unique about the model that we set up is it looks at both the near field and the far field. So it looks at what's in the room as a whole. So kind of in the sort of the well-mixed box portion of the room, what is kind of that far field exposure just by virtue of the number of people in the room and what the activity levels are, as well as the likelihood of them having come into the room infected. So it looks at that far field, but it also looks at the near field. So it looks at, I'm also being exposed to people who are closer to me. And so there's exposure both to the kind of room as a whole, as well as to the proximity associated with people. So both of those elements are taken into account in the way that we're coming up with the estimate. And then we also look at eddy diffusivity, both at the near field and the far field. And we have some novel ways of calculating and estimating what those values are. And all of that goes into this estimated risk of exposure. So that is, I think, all I was going to say about that. I was going to jump next to what the seat output looks like. So in the upper left corner of the screen, there's a tiny little picture that you'll see a bigger picture here in just a minute, but it's a tiny little picture of what the PDF tool looks like. And that's where you can go through and you can enter all of the information about the event. And then we have kind of blown up a picture of what the sort of the output portion of the PDF looks like. And the primary output is what I was talking about on that previous slide. It really is this group-wide exposure ratio. It's shown as a graphic. It shows that what that exposure ratio is for your two different scenarios, for your A scenario and your B scenario. So in the A scenario in this graphic, we've got an event that's into the high category. So it's slightly above what the baseline scenario risk might be, whereas in B, there's been enough dials have been turned to at least push that down to the medium category. So that really is the primary output. In addition to that, we also have some more of the numbers and details behind that for people who are interested in diving down into those details. So the output also includes the sort of an estimate of what that far field exposure ratio is. So that's a kind of that well-mixed box portion of the exposure. There's a near field exposure ratio. We also show what the exposure ratio is for an individual. So just to kind of circle back, all the numbers we're talking about and the way we present the numbers are the group-wide exposure. So it's each person is both a receptor and a source in the way we're looking at the model. So we're looking at kind of what that group-wide exposure is. We've also broken it down to say what's the exposure to a hypothetical person in the center of the room, kind of what is their exposure ratio if we think about it being just one person. And then we've also converted that to a dose, which we use to compute the likelihood of an infection for an individual, and computing that likelihood of infection that's based on basically the Poisson PDF, the Poisson, not P as in PDF file, is the probability density function of a Poisson distribution, which is the same model that's used under like sometimes you'll see Wells-Riley equations for the likelihood of an infection. It's the same math is what we used in computing that likelihood of an infection to an individual. So again, a lot of this is explained in more detail in the paper. But we wanted to kind of give you a flavor for what it is you're looking at. And I saw that there was I just saw a question pop up that is this available to anyone to use? And the answer is yes, it's available to anyone to use. Just be aware it is a beta version of the tool. As I mentioned, we have a manuscript that is out for publication and peer review. Once that has been peer reviewed and we're comfortable that it's gone through that level of I guess rigor and review, I think we'll take the beta off of the labeling, but at this point it is a beta version of the tool. So that is the sort of what the tool looks like. And I'm not going to spend too much time on these next slides, but we do want to at least mention the fact that we have demonstrated the applicability of the tool. This slide just outlines these are some 11 cases that we kind of actual events that we found enough data on to be able to understand what the spacing was, what the size of the event was, what the duration of the event was, and that we knew the total number of people who left the event infected. And so we were able to sort of take this case data. And if you look at the next slide, we took the case data for these 11 cases, inserted into the seat tool. And this is just a graphic showing what the seat result was for that exposure risk relative to the number of observed infections. And the biggest takeaway from this slide really is that for all 11 of these cases that we applied SEAT to, where there were a fair number of events that are fair number of infections that occurred following the event, SEAT did put this at least in the high, in some cases bordering on the very high exposure level. So again, that's not a full-blown validation of the model, but is at least a demonstration of the applicability of the model. And in the next slide, we actually show the actual correlation between what the SEAT predicted infection rate is and what the observed infection rate was. And we do compare that to what we call the Wells-Riley results, which is kind of, in short, kind of the easiest way to describe the Wells-Riley result is if we had just assumed a completely well-mixed box and didn't take that proximity also into account, the figure on the right, it's still good relationship. It's still a monotonic relationship, and it's still reasonable correlation. But with the SEAT, where we're starting to take the proximity of individuals into account, we actually ended up with an even higher correlation. And again, this is a demonstration. It's based on a handful of case studies. These kinds of things are very difficult to validate because it's only after the fact that you have data, and you don't necessarily always have all of the information that you would input into SEAT to know what the tool would have given you. Nonetheless, it gives us some assurance that the tool is giving a reasonable indication of the exposure risk. And then the final slide before I turn it over to Brian to do the demo of the tool is we wanted to mention that the tool has also been used in practice. So some of the folks that were involved in this Covert consortium, Brian, I don't know if you can switch to the next slide or not.
Sure.
So some of the folks that were involved in this Covert consortium actually were connected with the NASA Ames Research Center, and they showed the tool to some of the folks that were some of the industrial hygienists and health and safety managers at the NASA Ames Research Center. And they actually started using the tool operationally as they were looking at people coming back into the office. So this is, I think there's 70 or 75 cases here where it was just, case studies of people coming back in to partake in different events of different durations and different room sizes, and sort of what basically, and the details of this slide are really not that important, other than they have been using SEAT actively to say, okay, here's what I plan to do. What's my exposure risk associated with this? If it's too high, then what kind of adjustments do I need to make to try to mitigate that risk, or at least understand the risk coming in. So they actually have used that tool because they've got a lot more case studies than we do here at Signature Science, because we're a much smaller company. They've been using the tool kind of day in, day out. So they've got a lot of actual real world cases of how they've used it to make decisions about how they're going to try to bring people back in a relatively safe manner. So this is just an illustration of some of the data that they've generated as a result of that. So that I will actually stop talking now and turn it over to Brian. I'm not sure if I've gone over my time or not, but hopefully Brian will have a little bit of time to give you guys a demo of how it actually works.
Nice, thank you, Molly.
All right, hello. I'm Brian Schmoller, and I appreciate the opportunity to be here with you guys. And my technical background is in air pollution meteorology and in environmental engineering, despite my having worked in business development, as was mentioned at the beginning. So that I was applying my technical background in those areas when we made this model. So the first thing I wanted to point out about the model is that it is publicly available. We'll send you a link in our slides for how to get to it and download it. It doesn't cost anything, and it's available through our partner at the Covert group that Molly had mentioned. And we have both an SI version of systems in a kind of a metric version and a US customary units version for those that are not familiar with cubic feet per minute and would rather have it in more liters per second, for example. We can do both. So the other thing about the model is that it is running in is actually a model that is running inside a PDF, which sounds strange, but you can actually write code in JavaScript and have that running inside a PDF document. And we chose to use a PDF document to distribute it because it's an easy way to distribute something. And also, once you download it on your system, it's private. Nobody is seeing what you're entering into it. And we thought that was useful for some organizations and people that don't want to necessarily have their information shared with other organizations or have some concern about that. So quick overview of the PDF itself. It's 3 pages long, but all the important calculations pieces are on the first page. The second page is some technical background. And the third page is kind of a more in-depth instructions on how to use the model. So if you have any questions, you can go to the third page to get those answered. And so I'm going to walk you through a very hypothetical scenario. I'll try to do this quickly. How much time do we have, by the way?
Well, we're actually over time, so as quickly as you can
Okay,
do,
so
that would be great.
Great. All right. So let's say the first thing you would want to start off with here is to say, understand the group that you're working with, and that's you would describe your group in terms of their compliance with public health guidance, for example, and you might want to assume that they're average for your community. And you can also apply the specific vaccination rate for the group if you know it. And you also can apply some information about surveillance testing if that is being used in your group. And the next thing is you specify the size of the group between 2 and 250 people. And we're going to change one of these to 5 and keep one of them at 10. And you're looking at 2 scenarios, scenario A and B, all the way through this. And the next thing you can put in here is what's the distancing for the group. So you might have at 2 meters, might have at 0.5 meters, or you can enter a specific value here if you choose to. And and then the next thing is you choose the masking characteristics that are being applied by either group. Let's say they have N95 masks on and what % are wearing it. Let's say 100% are wearing it. And then you can, then you decide what activity is being engaged in. So you can change the activity as well. And that changes essentially the amount of emissions that are potentially happening for infected individuals. And then the breathing rate can change as well, where you can change their level of exertion, which affects the inhalation of anything that's in the air. And then you choose indoor or outdoor, and then the math is slightly different for the environment, for the indoor or outdoor environment. But as was said earlier by Chris, outdoor infections are very, very rare, and the model would sort of show that as well. And then the air changes per hour are also entered. And all the comments made earlier today about how that's an important factor and sometimes hard to measure is true. And some of the same guidance that was provided about asking people or using some lookup values, we give you both those. We have another, other version of the model. We actually have a way of predicting it from CO2 measurements as well, but in the current version we have published, we don't have that in there, but we'll probably put that back in at some point. And then you choose your room filtration scenarios. You can, choose no filters all the way up to HEPA filters. And then, and all the while you make these changes, the model adjusts. And then you specify the room size, the width, the height as well. And then the last area is where you're entering information about the local community. So, and this is essentially what drives what's the likelihood of an infected individual in the room. So, as that changes, that'll go up, and then we can enter information about the prevalence of a variant, and the model adjusts the relative transmission rates based on published data that we sort of recommend where to go to find this data in the instructions section, and then some information on the immunity, and then finally the results are shown. So that's a lot to take in. And real quick in this quick amount of time, but I'll stop here and allow questions for any of the speakers today.
Thank you so much to all our speakers. I'm pretty familiar with the tool that John Urek presented. I'm really anxious to spend a lot more time with Molly and Brian's tools. It's very exciting. And I see we have some more hands, so I will make this quick. But I'm sort of really curious how people are using it now, given the vast variety in prevention measures, especially across the US. Like, you know, that CDC recently published a map with different risk levels on the community level. So do you see people using your tool to match it to the community level and determine, you know, community-based prevention measures at that finer grain?
Well, this is Brian. I'll answer the question certainly that's new, that guidance came out and it really goes one step beyond transmission, as you probably realize, is that the CDC guidance is also taking into account hospitalization rates in the community. So that is not actually, you know, accounted for in our model. Our model really just focuses on transmission. So we haven't really sorted out the link, you know, sort of the relationship between the two. And, you know, I'm in a county right now in Virginia where it's, you know, we're high here and we're still wearing masks. And, but our transmission rate shouldn't be that high because the cases per 100,000 aren't high, but the hospital system has some large number of cases, you know, so we are still in a high county. So that's our answer for C.
All right, thanks. Gabriel, you raised your hand.
Hi, yes, thank you. It's Gabriel here from the National Institute of Occupational Health in South Africa. I would like to ask, we need to assess the risk for healthcare workers that are operating mobile COVID-19 laboratories. How would you suggest I go about it? And can the tool that Molly, you presented be used? Or would you recommend another tool for that? Thank you very much.
So can I ask a clarifying question? Are you asking about you want to also take into account the risk of transmission, not just from other individuals, but from the materials you're working with? Is that, am I understanding your question correctly?
Yes, basically, you know, those workers, they are in those mobile laboratories. They are basically like vans that go to the community, and then they have people coming into the van and they take a sample and they analyze the sample as well. So they have the equipment to analyze samples. So the risk is really from members of the community, from the materials, you know, it's a complex environment, I guess.
That is a complex environment. And I think the tool doesn't not take into account the risk of working with materials that are potentially infected. So I just want to kind of clarify that. It really is the person-to-person infection. Now, certainly you could take into account the fact that people are coming into a small enclosed area. So you could sort of look at the dimensions of the area, and then you have to sort of tweak the tool a little bit, because right now it just assumes a single event where people are sort of present for the entire time, right? Whereas in the scenario you're talking about, you have people coming and going. But I think there's ways that you could potentially sort of, we could think about how to enter information into the tool that you could still use it in that context. So I think you could use the tool to some extent, probably somewhat imperfectly, to get a sense for the person-to-person transmission risk in that scenario, but it doesn't take it at all into account the risk of working with materials, with substances. Yeah.
And then, yeah, certainly the ventilation of the in the van, if that's known, that would be important, as the previous speakers would have mentioned the importance of ventilation. And then, you know, the healthcare workers generally are wear masks well as compared to the rest of the population. So, you know, and generally are wearing better masks. So the masking, you know, is an important factor as well. But both those.
Thank you. I don't think they have any ventilation in there, actually, just maybe from opening doors, windows. So yeah, that would be tricky.
All right, thanks. Vanessa.
Thank you very much.
Oh, sorry. Vanessa Wolf raised her hand.
Yes, good morning. I'm just interested in how you control a glass building that has an open concept around ventilation and the transmission of COVID. So I'd be interested in which tool you would access for that. So if anyone has any input around that, I'd be interested in hearing about that.
I'm not sure who that's directed to, but I wonder, John, if you want to take a stab at that, or Chris?
Sure. It depends how big the building is. Our tool was designed originally for classrooms, and it works well for offices, single offices, and meeting rooms. We haven't really gone all the way and tried it out in large rooms. Some classrooms have lots of windows in Canada, so at least one wall. I'm not sure what the importance you put on the windows. You might explain that.
So it's a 5-floor building, no windows.
No windows.
So no windows at all. It's only glass. So it gets extremely hot in the summer and cold in the winter. I live in Vancouver, so cold
Okay.
is relative, but it's still very different, right, in terms of controlling temperature and the flow of air.
And inside the building, is it offices?
Oh, it's all offices and it's all open, completely open.
Yeah, the open offices are difficult to evaluate because sometimes you have barriers between the cubicles and things like that, and so the airflow can be quite an issue at times. But I would imagine you would have an HVAC unit, so you would be able to talk to the people who maintain it to find out, the size. If there are ventilation drawings, you might be able to figure out how much air is coming out of which vent. If you want to check that, you could get somebody from outside to come in and do an air balancing report. I can understand your thermal problems. I'm not sure where these architects who designed these totally glass buildings go to school, but I've seen problems in many such buildings. They should force the architects to work in those buildings. That might change their main and how they design them. I think that's about all I can recommend. You could use carbon dioxide to evaluate, but as Chris says, it depends on the occupancy. If the occupancy is normal, it might work, but you should also look at what type of filters you have in the system. If they've upgraded them for the pandemic, that will help. A lot of places are moving to MERV 13 filters or higher. So I hope that helps.
Thanks, John. It does.
And I want to do a question from the chat. This is Will Heller. How would you go about using the beta tool to calculate for environments up to 20,000 indoors or out?
So I need to talk to Brian about this. I think we actually have something built into the tool that kind of caps it out at 250, but the math theoretically still works even for that many people. So I have to go back and play with it to see if we could enter that many people. It might be the current version of the PDF just kind of puts a halt on that, but there's nothing in the algorithms that would prevent that from being applied. You just would have to enter all of the other information. We have not even looked at how it performs for a group size that big and if that changes the performance of the model. But it's theoretically you could apply the same math either way.
And I assume the 20,000 was people, not
That was my assumption.
feet or square meters.
right. How about Francois Hall? See a hand raised.
Hi there. I was just wondering about applying any of these tools in like much larger events, like sports, basketball stadiums and things like that. Has there been any calculations or any studies or anything shown that it'll increase or decrease transmission in those spaces? Or I'm assuming because of the large volume of air that the dilution is significant, and hopefully have really good ventilation systems.
So I think similar to the last question, I think the principles behind the model could be applied to that kind of setting. That wasn't the kind of environment we were considering as we built the tool. So, but I think that would be a possible area for expansion and further research to understand, if we took the same equations, the same algorithm, and applied them to that kind of setting and had that information, how would that impact the results? And then obviously we'd want to try to at least look at some actual data to see if that bears out. So theoretically it's possible. It's not what the tool is currently set up to do, and we have not done that work yet.
Thanks. Jack Caravanas, do you have a question?
Yes, how you doing, everybody? I enjoyed this immensely. I did some work with buses for a mass transit unit, and we were confounded with a challenge because what protects the drivers most and what protects the passengers most was really at odds. And I know this is a workplace sort of forum, but have you all struggled with what risk you're assessing, population versus workers, and how did you reconcile that? Because sometimes they don't even know, they weren't even able to answer the question when I brought this up to them.
So in our case, we treated everybody the same. If you're a person in the group, you're a person in the group, whether you're a customer or an employee or whatever. It didn't make any difference in our model. But I could imagine that you could have different control measures for the worker which we've all seen that, than the customer, let's say. So we don't really address that. It is interesting that there was one of the case studies that are in here that we went back to, to validate the data from, was a bus scenario in China early in the pandemic, and it did show a fairly well mixed infection pattern in the bus. It didn't really show any effect of proximity in the bus, much effect at all. So essentially the bus was well mixed.
If I can add too, our work in classrooms was interesting because obviously if the children are very young, they don't produce as much carbon dioxide as an equivalent occupant who's an adult would. However, their activity level is usually a little higher. So it got quite interesting to try to figure that out, because again, we just looked at occupants. We didn't differentiate between the teacher and the students, and we assumed a fairly well mixed room, which I think most classrooms are. But yeah, that was how we dealt with it.
Thanks. Shauna?
Hi, everyone, and thank you for the presentations. Shauna Mallory-Hill from the Faculty of Architecture at the University of Manitoba in Winnipeg, Canada, land of -30 weather, where 10% fresh outdoor air is probably a high achievement for us in our ventilation systems. A question for John or Chris, perhaps. I'm part of a group that's looking at the return to campus for our students and staff. Campus has been shut down mostly through until February, but now we're opening up to bring students and staff back to campus. Fully occupied, our campus houses 30,000 people in a variety of older and newer buildings. So it's a big challenge. And for me, it's an opportunity for teaching. So one of the things the Faculty of Architecture has done is we've built a number of these Corsi Rosenthal boxes. And I'm curious about implementing them in already mechanically ventilated spaces, because we're going to change the air currents in those environments. So I wonder about positioning them in the room if people want to use them, and how we might measure the performance in the field to get some data about how these CR boxes actually might help or hinder viral transmission. So Chris or John might have some comments about field measurements, so we can start to test how these things are performing in practice.
I'll try to give some perspective from that. So these boxes then, these are filtration units, is that correct?
Yeah, I think John presented them. They're basically a MERV filter, MERV 13s attached to a box and with a fan,
I
glued
probably
on
can't
top
give
of it.
much advice. My experience has all been around using carbon dioxide levels, and obviously if you've got filtration that's taking out particulate, it won't be taking out carbon dioxide. So I can tell you how not to assess the environment, Sean, and that's using carbon dioxide. I think beyond that, I'm afraid I've run to the limits of my knowledge. So maybe John can add something in there.
Yeah, the first thing you do is try to get as much outdoor air in as possible. And while I agree in Winnipeg in February, that's hard. In April and May, the outdoor temperature is exactly what the air conditioning unit wants to derive. So to save money, you can actually open up total 100% outdoor air when the air temperature outdoors is about 10 degrees Celsius or 15. So there are seasons when you can maximize the outdoor air and you can actually save money too. It's interesting, I just gave a talk on some of the critiquing some of the reports at the University of Manitoba, and the webinar is online, so if you want to see it, you can, they actually did exactly what Chris told us not to do. They went into the building and took carbon dioxide readings when hardly anyone was there. And they also took them outside, and it turns out the outside levels were higher than the inside levels, which means that the University of Manitoba has figured out a way of removing carbon from the environment, which is quite amazing. Yeah, we see a lot of ridiculous evaluations for air quality. What you really want is the air balancing report to find out how much air is coming into a room. And if there is insufficient outdoor air coming into a room because of cold air outside or whatever, then you need to add filtration, and that can be done centrally by moving to MERV 13 or higher filters within the ventilation system, or you can have portable air filters to supplement. And our spreadsheet actually calculates the equivalent clean air changes per hour that filters will provide. And so you can do that calculation. To evaluate them, I think there has been a paper or two published evaluating the difference that these make. I have done it with other portable air filters. If you get a measuring machine that can measure ultrafine particles, and you measure it around the filter and in the exit airstream from the filter, you can see a difference. That's not scientific, but it gives you an idea of how much. And when I've done that, I've seen quite a drop. So these things do work. You could do the same type of evaluation for the Corsi-Rosenthal. And yeah, the spreadsheet will give you the equivalent that provides for air changes per hour.
Just a quick follow-up, John. What I'm really concerned about is unintended consequences that these devices are placed in the room and they get in the way of proper exhaust and airflow in the space, so that we're drawing air back into people into the breathing zone by having these fans on the floor sucking air into the filters, right? So just wondering about some thoughts about, when people, where we're bringing the viral load into the breathing zone by putting these fans in the space.
Yeah, I've seen all kinds of concerns raised against these things, including the tripping hazard. Part of the airflow, and Chris said this really well again, we don't really know how the air actually flows until you put some kind of a smoke, or we used to have a a gun that would produce soap bubbles, and then you could watch them float around the room. But we also had smoke tubes and things like that. Unless you have a good understanding of how the air currents are moving, and most, I would say almost all workplaces do not have a good understanding, you don't really know what this is doing. And so, you know, if you want to bring somebody in who can, you know, help you visualize the air currents, that would help. But I've also heard people use it to argue that the windows should be closed, you know, especially people who are worried about the heat going out of the building in the winter. They want all, I think one school in BC, or in Ontario too, they actually nailed all the windows shut right in the middle of COVID. You know, ridiculous things. And the principle that you want to keep in mind is you don't want these units blowing air from one person's breathing zone to another person's breathing zone. And, you know, that's not a difficult concept to understand, and most people should be able to do that. The Corsi-Rosenthal boxes, if you use 4 or 5 filters instead of just one, the air, no, that doesn't work. It's the other way around. Sorry, that's wrong. But yeah, just you know, put ribbons on the fan and see which way it's going. There's lots of simple ways of figuring this out. You know, open some kind of personal fragrance that you can smell and see where it goes, where you pick it up first, things like that. Or you can get a professional in and let them visualize the air currents for you in some manner. But there's a lot of hocus pocus being spouted out about air currents right now, and so be careful.
Kevin Hedges, you have a comment or question?
Yeah, just so I actually I'm a big fan of the Corsi-Rosenthal box. I made one for my son's school, and the principal was good enough to accept it and put it in my son's classroom. It took me about an hour to make, and so we posted a link in the chat box, the Clean Air Crew, and it gives you some instructions about how to make it. I used 4 filters, and I put a cardboard at the base, so it was blowing up and it's pushing air up. And there's been a lot of work done in the US at the moment, like recently on the Corsi-Rosenthal box. So I recommend it. It can cost anywhere from about $100 to $200 to do yourself. It is a do-it-yourself fan, air purifier, and it's been shown to be as good as some of the really good models out there, a lot cheaper. So just stay tuned on that, folks. What I did want to say was, when I was coming back from Costa Rica, and I see the president of the Australian Institute of Occupational Hygienists carries one around as well. I've got an Aranet CO2 monitor, and I've actually got it synced to my phone, and it's just another useful tool in the toolbox to see what the ventilation's like. And when I was in this bus in Costa Rica, the windows were closed, and I was measuring the CO2 and seeing it going up. And I told the bus driver that, you know, if they open the windows, then the CO2 would go down. So we actually watched the CO2 go down quite significantly. But so that's just a bit of a background. But just the question has to do with, you know, it might be a challenge for people to get the air changes per hour. And I've thought a lot about looking at using a CO2 monitor to assess the air changes per hour. And so my thinking is, you know, you could probably put this in a classroom at the end of the day, you know, when all the classroom's occupied, and then maybe over time, look at the decay curve and then put that into an algorithm to look at the air changes per hour. It might be another simple way to feed the air changes per hour into the calculators. I don't know if anybody had anything to add to that.
I just want to comment on that real quick. You actually can look at the decay curve or the ramp up curve and make an assessment accordingly using the same same types of equations that you would use for the decay curve, right? So that's what we did in our model, and I'm eager to test it. that part of it. And, we pulled it out because, we wanted to test it before we put it as part of the paper, but it's something that I think probably works pretty well. I have my portable meter right here, and I've done similar things as I've walked around the world in airplanes and buses and whatever, measuring CO2. So
thanks, Brian. Okay, thanks, Audrey.
Yeah, if I can jump in. We've done it, and it works well in naturally ventilated places. Again, like Chris suggested, that you need to take the measurement and data log it for a long period of time. And we found the decay curve works better than the ramp up curve. However, if you have a number of different rooms that are all connected with the same HVAC unit, you will get a mixing between the rooms that can distort the signal. So you need to be careful that you've kind of isolated the room. Another way of doing it is using dry ice or carbon dioxide fire extinguisher and filling up the room with carbon dioxide and watching it decay. Ideally, what you'd want to measure is how much carbon dioxide is coming into the room, because if it's being mixed with other sources of carbon dioxide in other rooms, it gets a little complicated. But in a naturally ventilated room, it's pretty straightforward.
Thanks,
yeah,
John.
I'd agree that the decay curve is the more accurate way of estimating it. We were just interested in seeing whether the ramp up would also provide accuracy, and I guess we're not quite done with that, but we're going to look to publish those results.
Thanks.
I was wondering if Chris had a comment on that.
No, just a word of caution on using the decay curves. If it's a naturally ventilated space, you are assuming then that all of the air that's coming in is clean air. If it's being drawn in potentially from another part of the building, if it's a series of interconnected rooms, when we talk about air supply rates to rooms, they are clean air, recommended clean air supply rates. So if you're using the decay curve, you have to be sure that the air is not being drawn in from another part of a building that may well have, contamination in it itself.
Thanks, Chris.
It's interesting, actually. I did it in an airplane once, and I found out that they use dry ice to keep some of the food cold, so that complicates matters, obviously. And in schools, when the school buses idle in front of the unit ventilator air intake units, it really messes things up too.
Yeah.
Not to mention everybody looking at your meter and breathing all over it.
I see Marianne has just put a link to an article in there. It's a synergist article, different ways to approximate airflow, looking at CO2, which includes CO2. Thanks, Mary.
Are there any more questions? I haven't gone through the whole chat. I've saved it, but I don't want to leave anyone out. Any more questions? Well, I just want to thank all the speakers. It's been great. If you have any more questions, you can email the speakers. And I suggest presentations because they're just really great. And some of them have a lot of detail. I know they mentioned a few slides that had a lot in them. So just take a deeper look. It's really, really good. And yeah, thank you. Thank you very much.